Disparities in CLI treatment. These are our disclosures, including a new project that I'll talk about later that's funded by the American Heart Association. I'm certainly excited about that work. I have 3 goals for the next 8 minutes, trying to try to make sure I stay on time, given that I'm moderating as well. Don't want to have to yell at myself. So we'll describe some recent trends in major amputation, describe the race and healthcare characteristics that are associated with higher rates of amputation, and lastly, introduce some work in progress, which we hope might elucidate more effective ways to limit amputation in the most challenging populations. So first, trends in amputations across the United States. We published this back a couple of years ago in 2014, and we're going to update it soon. We just got the new data back. But what it shows is essentially a good news story. On the x-axis is the year, and on the y-axis is the number of amputations per 1,000 Medicare beneficiaries. And as you can see, the line is going down. It's almost a 50% decline over a 4-year period in amputations for critical limb ischemia. And these are the important amputations, above knee and below knee amputations shown in these 2 lines here. 4-foot amputations have remained largely stagnant during this time period, but essentially it shows that overall we've done a lot of important work in the last 15 years in the treatment of patients with critical limb ischemia. We examined, though, some of the variation that remains for this disease process and work we performed as part of the Dartmouth House of Healthcare. Shown here is a map where this shows any amputation occurring across the United States, and the lighter areas have rates of 1 to 2 amputations per 1,000 Medicare patients, while the darker areas are higher rates, 3 to 6 per 1,000. So 2 to 3-fold variation, and the darker areas show the problem spots across the United States. We looked at the variables to see what variables explain those residual trouble spots that still remain despite those declines, and it wasn't too hard to find differences. Each of these dots represents one of those hospital referral regions. There are 306 in total. And the y-axis here shows any amputation rate for Medicare patients with diabetes and peripheral arterial disease. You can see non-African American patients have roughly lower rates, 2 to 4 per 1,000, and not much variability across the country. But obviously over here, patients who are African American have much higher rates, up to 8 times higher, and there's much more variability. So race certainly is an important factor that we have to take on head-on. We examined this slightly differently. We looked overall at amputation risk per 1,000 Medicare beneficiary per 10,000 Medicare bennies overall. And overall amputation rates are relatively low, 6 per 10,000. If you look in diabetic patients, somewhat higher, 1.6 per 1,000 or 6 per 10,000. 24 per 10,000 Medicare beneficiaries if you start looking at just diabetic patients with peripheral arterial disease. But if you look at diabetic patients who are African American, have peripheral arterial disease, have diabetes, and live in certain high-risk regions of the country, the rate is 6-fold higher, 36 per 10,000 Medicare beneficiaries. We then wanted to examine some of the factors about the treatments that these patients received and look to see if it was a function of time and lack of effect or new treatments. White patients with PAD and diabetes have seen a generous decline in low rates of amputation that started back in 2002. Black patients saw a greater decline, but of course their rates started much higher, so they still, despite the achievements that we've made, remain the highest risk population. And Hispanic patients are somewhere in the middle. We looked at the consistency of hemoglobin testing, hemoglobin A1C testing in these populations, and saw some small differences. We saw that inconsistent testing, basically not getting your A1C checked as you should, or low consistency testing was slightly higher in Black patients, and that was, as you can see, the black bars in this stacked bar figure. That translated, though, into important results. Those patients with low consistency testing, those who were not getting consistent A1C testing over time, had much higher rates of amputation. And that difference was much more important for those patients who are African American, as you can see here. So the highest amputation risks occurred in Black patients with inconsistent testing, and this showed a 5-fold difference, unfortunately, for that population. What about access to revascularization? It turned out that revascularization rates, and this is endovascular revascularization rates, were shown here. They're actually higher in Black patients. That's what you would expect. If this is a sicker population, they should probably be getting more invasive treatments. So it didn't seem like it was hard to get access to expensive things like endovascular revascularization or open revascularization, as shown here. But simple things like just getting your lipids checked along with your A1C, those rates were uniformly lower for African American patients. And again, for A1C rates, again, lower in African American patients. What about health policy? If you look at payment models in Texas for the care of patients with CLI, safety net hospitals who disproportionately care for African American patients were paid $600,000 in Texas for the care of patients undergoing amputation. Revisions with bundled payments would actually take all those payments away from safety net hospitals, turning the $600,000 of remuneration that those hospitals received into a $200,000 loss. So even health policy is going to disadvantage these populations. So overall, it's a challenging problem. Black patients receive poor, less consistent, simple, and inexpensive medical care. They have universally higher risks of amputation despite access to expensive revascularization, and they're cared for by financially threatened healthcare systems. What are we going to do about this? That's obviously a pretty big row to hoe, as we say. We're going to start at the beginning, though, and this is how we're going to, we hope we'll make at least a dent in this trouble. This is a proposal that was recently funded by the American Heart Association between our institution and Brigham and Women's, entitled Understanding the Pathobiology and Predictors of Limb Ischemia to Improve Outcomes in Peripheral Arterial Disease and Diabetes. And Mark Banaka is leading this effort. This project has three parts. First, we know that the complex pathobiology in CLI is poorly understood, so Mark Feinberg is going to lead a basic science project looking at wound healing and microRNAs. We also know that it's difficult to identify how individual patients are going to respond to the different therapies that we have to offer. So Mark Banaka is going to lead a risk prediction and personalizing therapy project in the TIMI study group. And finally, my job, as when you've heard about some of the work here already, is to identify those populations that are going to be most challenging and the systems of care that need the most attention, and try to figure out how we can better deliver simple and inexpensive therapies in those populations. An important aspect of this project is it's not isolated to just academic institutions. We have community outreach planned in several ways, social media highways. Community outreach efforts are planned as well. Community education efforts are going to be part of the project at each of our institutions. And lastly, we're going to make sure that we continue fundraising efforts to continue this work. We hope that these synergies will help to begin to better understand the pathobiology, the predictors, the treatments, and the systems of care that are necessary to prevent CLI in these high-risk groups. So in summary, it's been a pleasure here today to share some of the challenges and where I think the amputations that we really need to deal with remain. I think the low-hanging fruit has been dealt with, and our iterative progress really needs to be in these highest risk populations, and I look forward to the work ahead. Thanks very much.